Hello, dear colleagues, friends and guests. Welcome to module number 3, Advances in the Safety and Treatment of Prostate Cancer. Welcome to the ESU-EAU course. Safety Data, mHSPC Therapy and Cardiovascular Disease and Risk Profile was my job to present. My name is Axel Merseburger. I'm a uro-oncologist from Lübeck University here in northern Germany. Here you have my potential conflicts of interests, my agenda, and I have divided this talk into three parts. I was asked to talk about the rationale why those modern treatments and androgen deprivation therapy has an effect on the cardiovascular system. Secondly, I would like to dive into other treatment modalities like chemotherapy, surgery, ADT, alone and in combination. And finally, and this is the biggest part, look at the treatment modalities we have and the associated cardiovascular toxicity. The question is, why does prostate cancer hormone therapy and especially nowadays the intensification affect the cardiovascular system? And as you see here in this basic research work, the GnRH agonists here on the left or antagonist have an effect on the T cell, which is, as you know from medical school or from your practices, heavily involved into those chronic inflammation, plaque instability, and then also thromboembolic events. And I've learned from cardiologist friends that especially those clot fragmentation or the plaque instability has an effect, and that the endothel is the key in why and how we get cardiovascular events. Plaque instability, inflammation in association with GnRH receptors and those blockers or agonists is shown here. One side we have stable plaque, as you see on the left side, and a vulnerable plaque with a thin cap and composition with rich inflammatory cells, which is a risk factor for any cardiovascular event. The GnRH receptor agonists and antagonists act differently on those T lymphocytes. Where you see the agonist here, increased interleukin 2, IFN gamma secretion, where on the other hand the antagonist completely blocks the receptors with no single transduction. And this is the hypothesis why in clinic we see reduced cardiovascular events, thromboembolic events, when an antagonist is used in advanced prostate cancer. So that's first short part on basic research, and this what I presented was based on also animal models and research. However, didn't present you all the basic research because knowing you are a uro-oncologist, you want to go into the clinic and see what we have there. And we have a lot. And as you see here, the treatment landscape and the options we have for our man with advanced metastatic or locally advanced or localized prostate cancer has really evolved through the last 15-20 years. And I'm keeping updating this slide with recent developments. Just some weeks ago at ASCO we saw the VISION trial showing a benefit of lutetium 177 PSMA compared to hormone treatment. And those are the novel options we have. Surely we have to think, we have to see what stadium we are in, what if it's an mHSPC, mCHPC, mCRPC and zero CRPC. So you really have to define when you choose the treatment. And regardless of what you have, it all equals up and ends into a therapy intensification. So what does it mean? When you have more therapy and increased use of hormone therapy, we also have an increased or potential increased risk of side effects and cardiovascular effects. The mechanism of action is well known, just to complete, when lowering androgens by blocking the hypothalamic pituitary gonadal axis, either by a GnRH agonist, like for example Lupron or triptorelin, or a GnRH antagonist. The only one approved here in Europe is degarilix. We have relugrilix approved in the US, but those are the options we have. On the right side, anti-androgens, bicalutamide, or modern treatments like apalutamide or enzalutamide, blocking directly on the androgen receptor. When comparing agonists and antagonists, there is a difference due to the mode of actions, due to the receptor blockage versus the increase activation. Here in the antagonists, the blockers, we know that it's associated with a rapid castration and therefore no flare-up. So I personally like this as a somehow fast treatment for metastatic prostate cancer. Once we have the diagnosis, then it has to be discussed with a patient depending on cardiovascular risk profile to stay on the blocker or to switch in the more easier formulation in some countries with 3 months formulation of GnRH agonists. But this is definitely something we will discuss at the end of this module. And I would just like to draw your attention on this slide because I think it summarizes pretty good how much data we have seen the last 5 to 6 years in metastatic hormone-sensitive prostate cancer. And then nowadays it's not enough to just give ADT. We have learned this following the Chris Sweeney presentation at ASCO 2015, more than 6 years ago. He showed us that the combination with docetaxel and ADT improves OS. Now we have OS approval for abiraterone, apalutamide, and also combination enzamet with enzalutamide. So really showing that therapy intensification makes sense. Again, looking at the hazard ratios, PFS-wise or OS-wise, just as an example, I've summarized the OS benefit and RPFS benefit of the Titan trial, the randomized phase 3 trial, showing an advantage of apalutamide in combination with ADT compared to ADT alone, just recently published with a long-term overall survival analysis. So we have a treatment intensification. So what does it mean for CVD toxicity? And I think here it is important to look at the patient. We need to see our men, and personally what I do, I send all my men which I suspect some cardiovascular disease or men with multiple hypertensive drug medication or a history of cardiovascular events, to the cardiologist and best or at least to the internal medicine expert to have a second opinion to judge on the situation and how to improve or maybe best tailor the treatment for the gentleman. And this I think is interesting, even though this is published some years ago. The incidence of cardiovascular disease in men with prostate cancer is high. We know prostate cancer is diagnosed in older man, elderly man, and when looking at the major CV events, you can see, especially from the onset of prostate cancer detection, the highest incidence within the 65 to 70, 80 years, you see also an increase. So the men really have a risk of major cardiovascular events when looking at this data shown here. What was surprising for me was this data. I mean, it's also pretty old, but still, I think, very in vogue and probably even more pronounced nowadays. It was shown out of those ZEOC and EORTC trials that cardiovascular disease is the second most common cause of death in men suffering from prostate cancer. So altogether, the whole story here, and this is also what we have to keep in mind when we operate those men with localized prostate cancer or submit them for radiation therapy as curative treatment, that we know that about 1/3 die of cardiovascular disease, as you see here in the EORTC trial, and not of prostate cancer. And we have additionally another 1/3 of other reasons, for example, other cancers or other diseases that lead to death. So we have to keep this in mind. This is not a minority. This is not just a handful of patients. This is like a broad disease aside the diagnosis. And I would like to show you this trial, this visual poster, and apologize due to the time limitations. I cannot show you like all trials and details. That's why I like the use of those visual posters, as the EAU is also doing nowadays. I think it's very handy, and you know in one view and one slide what this trial is about. This trial was a randomized phase 2 trial looking at 80 men where 41 received an antagonist and 31 the agonist with advanced prostate cancer and also pre-existing cardiovascular disease. It was published a couple of years ago in a journal of urology by Markel and colleagues, and they looked at the endothelial function before and showed that there was no difference among those two groups using the Endopath 2000 arterial plethysmography. So what was the result? And this comparison, and as said, it's not a large trial, however, it's a good made randomized controlled trial. That's why it's published in this high impact factor journal. And it showed that more cardiovascular and also cerebrovascular events, like a stroke for example, were seen in the GnRH agonist group compared to the blocker. You see 20% agonist versus just 3% in the antagonist. Surely we need to await phase 3 trials, and there's a Degalix trial pronounced still running. I don't have the results as of yet, but we will see them in the next years. So do we have phase 3 evidence? Yes, we have. And we have the HERO trial published last year comparing relugolix with lupron acetate. It was highly published in the New England Journal of Medicine. First author is the urologist Neil Shore, and by well-known colleagues here, the authors. And they looked at about 1,000 men that were 2-to-1 randomized in the blocker arm compared to lupron. And it was an oral blocker, relugolix, and compared to the 3-monthly subcutaneous lupron injection. The primary endpoint was testosterone recovery at week 48, and secondary endpoints castration, profound castration, PSA response, FSH at week 24. And you see the primary endpoint, the sustained castration level, was met. And also the key secondary endpoint, non-inferiority to Lupron, was met. You see the statistics here and the response rate, and I think this is also mirroring what we see in the clinic, that about 95%, 80 to 95% really have a good testosterone suppression with those hormone treatments, androgen deprivation treatment. And you see, this is a successful trial for relugolix in comparison with Lupron. Again, I said I like those visual posters, especially when we have a multidisciplinary panel here, and I would have a tough time really reading New England Journal cardiology publications here. For me, also a visual poster would probably help. But again, the HERO trial summarized for you. It's an oral, it's a tablet, good to remember compared to subcutaneous injection, the numbers of patients included, and the sustained testosterone suppression in those two groups, the mean testosterone level and also the mean testosterone level after discontinuation. And you see the recovery is very, very fast. So oral relugolix was superior to Lupron injection for rapid testosterone suppression. So can we translate those results to degarelix? Honestly, I suspect yes, but I don't know. We would have to prove in a clinical trial, since the application mode is different and this is a different GnRH antagonist. However, still again supporting especially the use in patients in men with prostate cancer with pre-existing cardiovascular problems. Lastly, here the toxicity profile of modern combination treatments like abiraterone, and we know from those approval and pivotal trials that abiraterone in combination with PrEP and ADT can have an impact on vascular or cardiovascular disorders and can have an effect on those up here shown problems. So again, a blocker might make sense, and especially having a focus on cardiovascular health is really important in our men who we treat with treatment. So here adverse events for enzalutamide out of the ENZAMET and ARCHES trial, and also would like to draw your attention on the hypertension. And as we know, hypertension goes along with the cardiovascular disease increase. So here also we have to keep an eye on when we have modern intensification of treatment, regardless whether it's chemotherapy, modern AR targeting agents like apalutamide, enzalutamide, or the abiraterone prednisone combination. So, dear colleagues, I hope I could summarize the knowledge on this exciting topic and deliver the message. Don't forget the cardiovascular system in our men we treat with advanced prostate cancer, because they really live long nowadays. And as we see from the TAC 700 trial or the PEACE trial, that we have long-lasting treatment translating the metastatic prostate cancer, hopefully in a chronic disease for years, where we have to keep our eyes on the cardiovascular disease, and that hormone deprivation therapy has an influence, especially as said here with the therapy intensification and length of treatment, in some cases even more than 5 to 10 years. So thanks a lot, thanks for your attention. I'm really looking forward to discuss and teaser, also looking forward for our next module scheduled on November 16th on future directions in prostate cancer management. Thanks a lot, stay safe, all the best.